We're going to talk about one of my favorite topics today. What is certainty when you talk about certainty as well? And why do you think it's so damn important for the chiropractor to have?
In a long form, there's certainty. If I was to drill it down to a shorter version, it's the knowledge and confidence that you can deliver on the promise of chiropractic. How certain are you that the body is self-healing, self-regulating, self-developing? And we apply our care, our adjustments to remove that interference.
This idea of there being like a cookie cutter approach. Have you ever noticed that, when your child goes along to the doctor and gets a course of antibiotics, that it's twice a day for the first week and then they work off them? These are based on, the reason that they do that is there is a way that their physiology changes with the antibiotics. So I just want to reinforce our listeners, don't fall into the trap of just because it's cookie cutter that it's bad. We are dealing with similarities in physiology here as well. Good morning. Good afternoon and good evening, folks. Hey, welcome to another episode, a very special episode of the Marketing Your Practice podcast, the podcast where I have the pleasure of simplifying the marketing and the mindset so you, the chiropractor, can increase your income, your impact, and your enjoyment in practice too. In today's episode, we're continuing our journey down memory lane where I'm sharing with you some of the most downloaded and requested episodes over the last 5 years. And today we're talking with a great Martin Harvey. Today's episode has the potential to literally revolutionize your practice. And I know that they are really big words. One of the questions I'm often asked is, what are the key characteristics that go into building a really epic chiropractic practice? And right at the very pointing end of that is certainty, a rock solid certainty in what you do and the value that you deliver to your patients and the wider community makes up for just about every other shortcome that a chiropractor can have. But getting this certainty can be incredibly difficult. In this episode here, Martin and I dive deep into the ingredients of certainty, and Martin is just one of the sharpest chiropractors going around. And I know this particular episode here is going to help you serve more people, change more lives in your community. So let's go back and talk with Martin all about how do we increase our certainty in practice. Enjoy. Martin Harvey, welcome to the Marketing Your Practice podcast. Buddy, how the heck are you?
I am really, really good. It's great to see you. And as always, great to be back on the podcast. I sort of feel like I've got to try and catch up to Dr. Sullivan somehow. I've got to try and chip away at his lead.
Yeah, absolutely. We'll keep working at it there as well. You're back to your busy beaver kind of self again. Just had a weekend down in Tasmania. Yes. Teaching chiropractors back down there as well. We're going to talk about one of my favorite topics today. I spent, I think, the first 10 years in practice on a quest for certainty, which I sometimes kind of bracketed with confidence, because it seemed to me to be the elixir that, I kind of saw these other chiropractors out there and people wanting to know, like, what do you say? Like, what do I say in my new patient visit? And what do you say to get it? And I thought, none of those things really matter if I don't have the certainty that kind of sits underneath them as well. So let me start with this. What is certainty when you talk about certainty as well? And why do you think it's so damn important for the chiropractor to have?
Yeah, I guess I have I went through the same journey where I remember going to seminars as a student and hearing that certainty was sort of the key element. And I think I remember listening to these sort of bootleg tapes from the US, and I can't remember who said it, but I remember saying something like, who you are speaks so loudly, I can hardly hear what you say. And it sort of struck me as one of those things that was like, there's an element behind it. People can be practicing the same technique. They can be using the same practice management approach. They can be using the same communication templates or scripts or whatever, and get very, very different results. And I think certainty is different to confidence, but related. There's sort of one of those Venn diagrams. And so certainty, when we say confidence, we're often sort of talking about how much you value your own ability to do something. To me, certainty is a little bit bigger than that, in that, yes, you have your confidence in your ability to deliver an adjustment. You have confidence in your knowledge of when to deliver an adjustment or provide any other form of care and when not to. And you have confidence in your ability to explain things in a clear and succinct way. and it's coupled with a understanding, not a faith, an understanding and knowledge of the potential impact of applying chiropractic care. So it's sort of this confidence in your own skills, as well as a knowledge-based, I've thought about this and I know who I can help and how much I can help, how much potential I have to help them. And also sort of a certainty or confidence in being okay that it's that sort of 80-10-10. 80% of people are going to get really, really good results. 10% of people are going to do a little bit better, and 10% of people, for whatever reason, haven't read your textbook, and you probably need to navigate a way to get them the help that they need, that it may not be with you. So that, in a long form, is certainty. If I was to drill it down to a shorter version, it's the knowledge and confidence that you can deliver on the promise of chiropractic.
Yes. For me, I don't know, I often wondered that there is a societal belief that I bought into, that chiropractic is unscientific, that there is a level of quackery, that there's also, we're perhaps not all that qualified, maybe not even safe as well. And a lot of that kind of really fed into it was kind of certainty of, like, am I a valued member of a healthcare provider team as well? Like, all of those things that, I don't imagine, I don't know, like, do you think that the medical profession worries about certainty in the same way chiropractors do?
Well, no, I think we've got an extra challenge for certainty, and we certainly don't. One of the things that really, and part of the reason that I want to talk about certainty is that I, for a number of years, taught a certainty course. But one of the things that prompted me to really explore where certainty came from was a chance encounter I had. This is going back years and years ago, but it was sort of a couple of things that happened step by step, or sort of close together. And one of them was, I went for a walk with my dog, and I happened to run into somebody walking in the same park with me, and our dogs were sort of playing, and I ended up chatting to this young woman, and I had been in practice for a while at this stage, maybe 6-7 years, and she was a student physiotherapist. And I was sort of, I'm curious, what are you doing? She was doing a clinical placement, and she was working in a rehab centre where they were working with people who were inpatients in a rehab centre that had had physical injuries, and they had this rehab process. And when she was describing what they did with them, if I can be really direct, and I don't mean this to be sort of derisive of physiotherapy, but it sounded pretty shit. Like, it just all sounded like not that much impact when you think of the sort of stuff that I feel like we would do with somebody who had a fairly significant physical challenge. We've got the power of this neurological input that can kind of reset things pretty rapidly and with impact. And she was doing this very, not passive, but very minimal input stuff with these people, not expecting, and doing it daily, except for the weekends, that, it was 5 days a week. It was daily, except for the weekends, and that people would have this daily regimen for 12 weeks. And what struck me was that she had, as a student, not having graduated, she had absolute certainty in that this was the best thing that people could have. But from the outside, I looked at it and I go, it sounds really shit. You've got a bad product, but you're certain in it. Whereas I think for a lot of chiropractors, I had this insight. We've got this amazingly impactful suite of skills, most especially the power of an adjustment. And we lack certainty in it. And some of that, is it scientific? Is it valid? And I think there's other reasons why certainty tends to be lower, but that's certainly part of it. That there's that sort of cultural authority aspect of it, that where we come in with a sense of, look, there's a lot of criticism of our perspective. Where there's smoke, there's fire. Maybe, I shouldn't be so certain in this stuff. And I think that's part of the reason why I sort of look at certainty, particularly with chiropractors early on, but it still happens to people after 10, 20, 30 years in practice, that often, if you haven't done the work to clarify your thinking around things, it's this roller coaster of certainty. And you go along and do an adjusting seminar or a neurology seminar or a, Dan Murphy, Heidi Horvick, whoever seminar, and you come out of it super certain in chiropractic because you've got this picture of the value of it in through this lens of whether it was a science-based lens or a technique-based lens or whatever else. And then it sort of leaks out over a period of time when you run into the uncertainty of daily clinical encounters of people saying things that are critical of chiropractic, you quacks, you're dangerous, you're unscientific, or you run into clinical scenarios where there's an uncertainty attached to it in terms of, are you delivering on the promise? So, somebody comes in and says, I don't really know whether this is working for me, or you hurt me, or my friend said that I should be doing Pilates instead of this, or whatever it is. There are these things that can kind of undermine your certainty, and it sort of leaks out over a period of time. And to me, unless you do the work to sort of clarify the paradigm that you're practicing under and some other things, it's always going to be this roller coaster. Yes. But your experience maybe helps you sand off some of the rough edges of that up and down.
Yeah, I think it's interesting too, because I'm kind of replaying in my head some of my journey. And initially when I wanted to clarify that stuff, the solutions were given to me more from, there was an element of practice management to try and provide certainty there too. And if it wasn't that, it was kind of answered like, well, how often do you get adjusted? Well, once a week. So therefore that's what you should recommend to other people. And I'm like, well, that's a reasonable way to go about finding a solution for it. But is there anything else that, I'm sure that the answer that this physiotherapist student with their 5 times a week didn't come from, that's a great way to build your practice, or if you injured your elbow, how long would you do it there too? It seems that for some reason, and you're one of the first to, and we'll talk about the framework in a moment there, to go, no, there's a very obvious way to answer this question. There's supportive science and logic that can really point us in a direction that can kind of help us answer these questions as well. I don't know why it's taken so long for the profession to kind of have that mature conversation. Why do you think that is?
I think that there's a few elements. The first one is, if we look at it as our procedures, so the things that we say and do in practice, if they're aligned with our paradigm, which is sort of the model of care that we provide and the rules around what we do and when we do it and who we take care of and who we don't, if the procedures align with the paradigm and the paradigm aligns with the philosophy, then that creates a really cohesive sense of certainty. So if we look at our physiotherapy student, physiotherapy doesn't have an alternate philosophy to the predominant health philosophy that our culture has. They have more or less the same thing, which is largely a symptomatically oriented philosophy with maybe a little add-on of prevention, whereas chiropractic has other elements to it around performance, and we have a different perspective around the role of symptoms, and that there's the highest value for many of us is in applying care where, regardless of symptoms, and in fact, when you don't have symptoms, that's where the real juice and the life-enhancing aspect of chiropractic can come in. So we have this philosophy, excuse me, but then we often don't then take that. And most of us, if we're asked about the individual elements of that philosophy, we're pretty certain that they're good observations and they're robust observations. So if we look at one way of stating them, and I know this isn't the 33 principles, but if we were to not go through them individually, but look at the 3 that most impact our provision of care, it would be, how certain are you that the body is self-healing, self-regulating, self-developing? And most people that I ask go, yeah, 100% that is the way that it is kind of set up to be. And then the central role of the nervous system in regulating all physiology and therefore healing, developing, and I've forgotten one of them. What is it? Healing, regulation of function, healing and development. And then the final one, the sort of clinical application of that is, if we find a source of interference to that nervous system function and we apply our care, our adjustments to remove that interference, regardless of whether somebody feels a change with that, that is good for how their body is functioning, how it's able to heal, regulate, and develop. And so most people, if you ask those 3 things, how certain are you? They go, yep, I'm 100% certain in it. However, we haven't then aligned or clarified our paradigm and then clarified how we'd apply that. So our physiotherapy buddy, she didn't have this alternate philosophy, and then she had a paradigm. And one of the really interesting things, and when we look back to sort of a framework around, one of the things I think can really massively upgrade your sense of certainty is they applied very, very routinely a model of care based on understanding of soft tissue healing timeframes.
Yes.
So that you're looking at an injury in their context and saying, well, look, if there's muscles that are involved, then muscle healing timeframes are probably somewhere in the range of 6 to 12 weeks, and we'll have a way of grading severity, and that will give me kind of a model of expected timeframes for outcomes. And then the severity and the chronicity matrix will then give me an idea of how the input should be graded up or down to compensate for that. And then if somebody then has a more significant injury that has ligamentous or disc impacts, then we're going to expand those timeframes because those tissues take longer to adapt and remodel. And similarly, neurological changes that are associated with it might alter those bindings. And so they have this sort of understanding that soft tissue healing timeframes should set the overall timeline, and severity and chronicity should set the intensity levels of your input and the person's home input.
Yep.
So they've got a paradigm of, well, then my interventions are designed to have an impact on the integration of those tissues, the response of those tissues over that time frame. And that's sort of a really simple paradigm that you can apply. But it's because it's clear, because it's got guidelines, it's sort of clear to see, oh, this person is doing what I might expect because of the timeline and our analysis of their severity and chronicity, and this person isn't. So there's that alignment of the philosophy to a paradigm, and then their procedures are sort of more or less, you don't question them because they're aligned with the paradigm. I'm just trying to change this thing, and I might have 3 different tools. I might be able to do a hands-on physiotherapy muscle technique, or I might have them doing various modes of exercise, or I might be applying some sort of machinery, electrophysical therapy sort of stuff. And there's a bit of nuance in how you'd apply that, but my paradigm is clear. And so my procedures, so long as they align with that paradigm, all make sense. I've got certainty in it straight away as a student. So the challenge for us is we've got that alternate philosophy, and we then need to think through how we apply that. And we also have some fairly different paradigms of application. So I don't think there's one paradigm of chiropractic. I think there's a bunch of different ways that you can apply that, but doing the work to apply that then makes it super easy to work out, look, procedure wise, what am I going to do? And I think sometimes, go on.
Are there any shortcomings in us looking at subluxation as an injury and taking that same thing that says, look, we've got a joint here that has components of change in movement, too much, not enough there too, associated soft tissue and neurological changes there as well. And even if we take into the idea of a physical, chemical or emotional stressor that caused it there as well, are there components of it that could not be just addressed as an injury?
No, I don't think so. I think so long as you're not wedded to the idea that an injury has to be symptomatic, I think it's a really important thing for us to recognize that asymptomatic joint dysfunction, subluxation, whatever term you like to use for it, is a really common and important thing for us to be aware of and address. I think that's one of the key things that is able to create a huge amount of certainty for people, is to borrow from the physiotherapy profession, where they've done a really good job of saying, let's look at, and they're simple frameworks, but they are really transformative in terms of the clinical application of akin.
I think too, when I think about an injury, the two things that come to mind without thinking any depth of it is symptoms and is trauma. And then we tend to think of trauma in terms of macro. I tend to think of trauma in terms of macro trauma, where subluxation is often without symptoms and very often without macro trauma as well. This, chronic buildup of postural stress there as well, and or, the components of, emotional stress changing physiology as well there. But otherwise, I've not actually ever classified it in my mind as an injury, although that's very much the way that I've looked at it. My pathway through to certainty was looking at it here and saying, look, as a neurological and biomechanical unit, what is going on here? What do we have? Aberrant range of motion, inflammation, et cetera, and then gave me directions to go as well. So
I think, if I can just interrupt there, I actually think that's a really useful part of it.
Yes.
And the adding the injury concept around it is really just, and if injury isn't the term to use, you can look at it more as what are the sequelae of having this change in biomechanics and neurology. But it's really looking at what has been the impact of this having been there for a period of time, so that I can then get a sense of moving forward. Because a huge number of the ways that people lose certainty is in not being certain how to, first of all, sort of track that people are improving. But even if they've got some good tests to know that somebody's doing better separate to their symptoms, because that's a really important thing. If you look at the physiotherapy model, because it's built on that idea of symptoms are what matter, the most important thing for you to measure is their symptoms. If ours is saying, one of our core ideas is you can't judge how healthy you are or how healthy your spine is or how well your spine is by how it feels, you probably want some good ways of measuring whether they're doing better. The next question past that is, if they are doing better, could they be doing better more quickly? And for you to have a framework of answering that, you need that time frame piece to some degree answered. Because there's somebody coming to you and saying, I've been coming in for 6 weeks and I'm not feeling any different. That's a question that can either be, and this is where that sort of practice management piece of the puzzle can be an important but incomplete answer to it, because often the answer there is, well, we've got you on a 12-week program, and everybody's on a 12-week program. So to me, there are some clinical scenarios. If somebody has a fairly recent development of subluxation and not a particularly severe level of subluxation, my paradigm would say we should be measurably able to demonstrate significant change in that time frame. Yes. And there would be other people where I would look at it, if my testing shows high levels of chronicity and high levels of severity, 6 weeks, I'm not surprised there's nothing changing. It's just that's expected because of the understanding of the time that it takes for physiology to change.
Yes. There's 2 things I want to touch on here as well. I'm going to start with this. Too often we shy away from, and I hear other practitioners shy away from, this idea of there being like a cookie cutter approach, 3 times a week for 6 weeks, twice a week and whilst I'm not for a cookie cutter approach per se, when patients ask me this type of thing, I'll often ask them a question back and say, have you ever noticed that, when your child goes along to the doctor and gets a course of antibiotics, that it's twice a day for the first week and then they work off them and they go there for an ear infection. But when you went there for a bladder infection, you got the same antibiotics and you got the same recommendation, and one of you was 7, one of you is 37. These are based on, the reason that they do that is there is a way that their physiology changes with the antibiotics independent of the person. And whilst you might have to have them stronger and longer per se, an adjustment is much the same way. So I just want to reinforce our listeners, don't fall into the trap of just because it's cookie cutter that it's bad. We are dealing with similarities in physiology here as well. Yeah. The second thing in there too, I was just thinking about it too, elements of certainty are, one, I need to find an objective way of finding this thing, which I'm happy to call subluxation. Yep. I need to have an effective intervention that changes the above identified finding. And then I need to have, again, a way of remeasuring the thing afterwards and see, does it change? Now, if I can do those three things there too, then I got to tell you at this stage, it's fucking hot dog. Like that's it. Like really, once you get that in place, and then you can start to take in those other things in place, and also give yourself a break that there is still art to this as well too. You have a framework for this. We've sort of danced all in around there too. And full disclosure, Martin teaches a course on this, which I'll tell you guys about at the end. I've done it. It's freaking brilliant. To be honest, everything Martin does is brilliant. And just from now on and all episodes going forwards and all ones past, when Martin does stuff, just buy it. Okay. You'll be very, very grateful that you have. And I have said this to a lot of people, and I've not ever had one person come back to me and go, Angus, that was a waste of money. They, like me, just continue to fall more in love with his brilliance. But let's talk about that framework as well. And we can give the chiropractors some homework to do with it, because they can do it themselves. Or if they want some more help, if they want speed of implementation, they should buy your stuff.
Yeah. All right. Well, thanks very much for your positive comments about my stuff. I really, really appreciate it. Feeling like I'm blushing a little bit here, so I'll move on to
awkwardly just kind of the other way.
Yeah. So really, so in the program, the first step is that I get people to essentially do an audit on where they don't feel certain or where they do feel certain, because that's a really useful exercise to do. Now, there's a survey that we run people through, but if you were doing it solo, the first question really is the question that I asked you beforehand, because the overall flow of what I'm trying to do is start off with, are you certain in those core ideas of the philosophy, self-healing, self-regulating, self-developing, nervous system's master control system? If it's being interfered with and you adjust people and the interference is reduced, that's a good thing in all those domains. If you're pretty highly certain in that, then I think you might get a lot of intellectual enjoyment and gradual expansion of your understanding of chiropractic by exploring with philosophy, but it's probably not where your certainty dips. But we would then look at, in terms of paradigm, I would be looking at those questions that you were just talking about there in terms of testing. What is the model of subluxation or joint dysfunction, or whatever term you want to use, that you use in your practice? How do you define it? How do you measure it? And how do you measure it visit to visit, so that you know where you're going to apply your adjustment, where you're going to apply your skill? How do you know that you've finished for that visit? Then similarly, how do you apply that model in terms of measuring progress over a period of time? Because we've got these soft tissue healing timeframes that go in typically 6 to 12 week cycles. But, say if we're looking at somebody with significant involvement and adaptation or maladaptation of ligaments and discs, you could be talking 9 months, 12 months, 24 months that it's going to take. But over a series of those, how can you track that separate to your daily analysis, that this person is improving in the function of their spine as aligned with that model of care or model of subluxation? So there's the testing piece of it. And then there's another piece around that, which is what I think of as clinical rules, because we've got that very specific part of it, but often people will feel uncertain in other areas. And so I'll give you a couple of examples. The scenario that I often give to people to sort of illustrate the overall concept of it is to ask them two parallel almost case studies. So if somebody was to come and see you and they said, oh, look, I've got a bit of a stiff neck, and you ask them other questions and they go, oh, look, I guess gradually over the last year or so, I've just had a bit of brain fog and I've just been feeling not kind of as energetic as I have previously, and just, feel a bit flat. Most chiropractors, if asked, how certain are you that you may be able to help this person with their stiff neck? But bigger than that, you may, because of your understanding of afferent neurology and a bunch of other things, you'd be reasonably certain that they may notice some improvement in some of that other stuff, the brain fog and just feeling a bit flat. Most chiropractors are like, yeah, I'm pretty sure that I'll be able to help that person with that area. Equally, if somebody came to see you and said, I've just had the worst headache I've ever had in my life. I'm now slurring my words and the right side of my face is starting to droop. And if I poke my tongue out, it goes on a weird angle. You could be equally certain that while in the future that person might benefit tremendously from chiropractic, right now they need to be going to the emergency room because they're probably having some fairly significant neurovascular issue, and adjusting them is not a great idea. And there's a whole lot of more subtle things that there's a huge amount of certainty in defining whether they are your job or they're not your job, because people can have their certainty rattled by taking on things that probably they don't necessarily have the paradigm and skill set to help with. So let's say a subtle example would be peripheral joint subluxations. So you can look at it and you can go, well, if somebody comes in and says, can I check your knee? You could make the example of, well, it's not the spine and that's sort of what I'm about. So no, I won't do that. But you could equally make the claim, well, they have joint receptors, mechanoreceptors, nociceptors that would also cause disafferentation if they weren't working properly. So maybe they should be part of my role. And I don't think there's a right or wrong answer to that, but I think you should be clear on it so that you then, if we go back to that role of certainty, it's to give you clarity in terms of your communication and your procedures. You go, well, yep, that's not really my area, or yes, I can do it. And here's the communication that delineates when I will say, actually, you need to go and see somebody else about that. But knowing that in advance is really powerful in terms of certainty, because it allows you to make decisions and not feel like, well, how big do I allow this to get? I've worked with chiropractors who are sort of like, they get uncertain because stress impacts people's development of subluxation. And does that mean I should be, if people are having a really tough time in a relationship, I should be helping them with that? And, people have, to take a really extreme example, people not having a good sex life is bad for their stress levels, is bad for their spinal nervous system. How far do you want to take this? Like, it's just being clear in this area. And I say that as, a jokey example, but there are a lot of things around that. Another one that I think can be really...
I say that not because the conversation that Angus and I were having beforehand, in which case, buddy, the sex life, it'll get better, okay? Just it's time at the moment, all right?
I set myself up for that.
And it's not because you're subluxated as well. So I haven't been missing anything with regard to my adjustments are great. Nicole just needs time, all right? So I've told you that a number of times. So yes. Anyway, move on.
Back to blushing.
Yeah.
So this area of rules is really important. And so it can cross over areas like vaccination. In Australia, we have rules that define whether you should or shouldn't speak about vaccination, but that's not always the case for all chiropractors around the world. But being clear on, is it your job or isn't it your job, is quite liberating in terms of promoting certainty.
Yes. I learned in the coaching course that I did last year, we did a lot of work in around boundaries, and I love it because you either have the pain of setting the boundary or you have the pain of resentment. There's always pain. One of them you get to choose though. So if you lay down clearly, goes, yeah, man, I'll adjust your knee. I love doing that. It's easy. I'm great at it. The 250, my model there as well. But, if it comes to doing, there will be a line for you. But getting clarity in around where that is and taking the time mentally, emotionally, and the pain to get clarity in around the boundary there, I think is super valuable as well. Or if not, resentment is what is going to kind of kick in. So I love it.
So resentment's one piece of it. And there's also if we look at all these clinical things, a really important thing that I think can be a bit of a flag of where you are losing certainty. So if people are wanting to sort of increase their area of certainty, the mechanism that I suggest that you do is anytime you feel anything but 100% certainty when you are in a clinical situation, is you write that down and you say, the next time this happens, this is what my rule is. It's what's called an if-then rule.
Yes.
So it is the mechanism for creating these rules over a period of time. And if we look then at the effect as well as resentment, so you end up doing things that you're sort of like, oh shit, I don't want to be doing this. I don't feel like I'm good at it, or I don't feel like it's as important as the other stuff, or whatever form of resentment there is. All of these things feed into what I think is clinically one of the biggest causes of a loss of certainty is not knowing when you should be done. So if you look at the really certain chiropractors, from a clinical perspective, you observe them and you're often surprised at how little they do, because they have prioritized this is the most important thing. And if you look at the least certain chiropractors, my observation would be they're doing more and more and more and more and more things because they feel like if I just cover every base, everything that this person could ever possibly need, that's the path to helping them most, without recognizing what I think is an important distinction, which is sometimes doing more overcooks things. Sometimes it reduces the body's ability to adapt to the most important inputs. And so less is more is often a better strategy for them and for you.
Yes.
But having the certainty to do that, though, requires you to be certain in what your end point is. And that loops back to what you were talking about in terms of those end indicators, and then these rules that add on to it. So for a very specific example of where I've seen uncertain chiropractors create a bit of a knot for themselves is in the area of soft tissue work after an adjustment, before an adjustment, whatever your model is. However, a lot of them will do it as a way of sort of feeling, I'm not certain in the value that I'm providing, so I'm going to do a bunch of this so that it feels to them like I'm doing more, and the $70 for the adjustment feels more value. And then there's so if we're forming a clinical rule around it, again, there's perspectives. I'm not saying you should or you shouldn't do any, but you should have a way of knowing when you do it and when you don't. And it should be based on your paradigm. So if we look at that paradigm of subluxation we were talking about, we've got this core idea of a joint that's not moving the way that it should. It's creating abnormal stress or strain on the surrounding soft tissues. They're richly innervated with mechanoreceptors and nociceptors. The abnormal stress or strain is going to trigger some changes in there where we get decreased mechanoreception, increased nociception. That combination is called disafferentation. It's going to cause some changes in local spinal cord mediated reflexes, a whole bunch of things to go on in the central nervous system. But at the spinal cord, the body's response to those change in spinal cord mediated reflexes that's going to alter the neuromuscular control of that segment of the spine is going to be to increase the local activation of postural muscles. So if we're talking the lumbar spine, it might be quadratus lumborum, piriformis, psoas, whatever. You could make the argument that doing something to address them might help the body unwind that subluxation better, or you could make the argument that it's going to destabilize it and make it harder for the body to adapt. This is one of those things where there isn't research that shows, to my knowledge, whether one way is objectively better based on outcomes or better based on pre-post range of motion, pre-post EMG, or any of those things. So you've got to find a way of sort of defining when and where you do and how much of that you do. Otherwise, that's one of the most common pathways out of certainty.
Yeah. And I think too, if you haven't taken the time to think critically about this, the most obvious measurement for is there something for me to do is this painful? Therefore, the conclusion afterwards, after I have my intervention, is this less painful as well? And very often, as you were mentioning there before, this is a complex neuro, biomechanical, histological changes that are going on that, regardless, anything short of some kind of injection of a numbing, the intervention is not going to happen there as well. I was thinking, so going back to this too, I had several indicators of whether my adjustment had done what I wanted it to do. None of them was, is it less painful for you? So
that's a really important distinction. For most chiropractors, if we look at that flow that we're talking about, we want philosophy, paradigm, procedures to all line up. The endpoint, the procedure of what's the test that works, that is less painful would make 100% sense if you started off in that physiotherapy philosophy of our goal is to get rid of your pain. That's the end goal.
Yes.
If you have a philosophy that's different to that says,
Yes.
where we would like your pain to go, but really what we're about is this other thing, then you need to have ways of telling that you've delivered on that other thing. Otherwise, we're going to default to those pain-based things. So,
but,
it's gone.
I would wonder, though, even inside of that, even in a physiotherapy type sort of model, where if we took, let's say, again, this will show the limitations of my rehab knowledge with regards to peripheral joints. But let's just say that I'd broken my arm, therefore had not bent my elbow for a long time. I'd lost range of motion there too. I would say almost the objective of my care as a physiotherapist is probably to induce pain. And it might be reasonable that after you finish some care with me, that this is actually more painful. And I've done my job because I'm really clear in around what my pre and post is. And this is where the benefit of the physiotherapist being able to say, yes, I know it's more painful now, Angus, but straighten your elbow, see how much straighter it gets. So there's confidence, there's some kind of objective finding there. And that's why it was never a stress for me when a patient hopped off the table or said to me, oh, Angus, it still hurts there. And I would go, and I was very happy to go, let me just check that for you, Martin. No. Legs are better balanced. This is changing here. There's a better range of motion that's changing through there. That's enough for today. I'll see you on Thursday. And my confidence and certainty was enough for that person to go, great, just wanted to check. Off we go from there too. But without those objective measures for me to kind of look at, underpinned by where I see pain and symptoms in the hierarchy of what's going on there too, you do end up without boundaries and so on and so forth there too. So, love it. Beautiful.
Yeah. So I think in terms of running through that paradigm, then what we've clarified there is we've worked on the philosophy, and then we've said, all right, applying that philosophy in a less abstract way, because those initial ideas super abstract. And paradigm is less abstract. It's sort of what's the model of joint dysfunction, subluxation. Attached to that, what are the clinical rules that I will use? And then all of that then dives into the procedures, which is how do I measure that on a visit to visit basis? How do I measure that with a lag? So if we go back to that physiotherapy model, if we use so yes, in the short term, visit to visit, the measurement of success on one visit is, look what I can do with my elbow, a functional thing. The measurement and that's a lead indicator, the lag indicator, the indicator that you should see over a period of, depending on their time frame, 6 to 12 weeks, let's say, for instance, is pain should reduce as well. Now, we need to have the equivalence of that. There will be, I don't think it's really, let's say EMG testing as an indicator, as an outcome. It's not a good test visit to visit. It's expected with people who are chronically subluxated for that to go pretty crazy as the spine is adapting. But over a period of time, we've got some expectations and some frameworks for it. For other tests, we're expecting leg length to change instantly. And if you apply your clinical care and there's no change in leg length, then I would argue that, you might need to look at your technique, or you may have more to do to get that person a step closer to where they need to be.
Yes.
But having a coherent suite of those tests in each of those domains is super important. And then it sort of raises one of the most important things, which is often the testing that we do on a lag, like over a period of time, isn't always aligned with our philosophy, would be my experience. So if we're looking at the big picture of chiropractic, is this impact on the nervous system and the central nervous system, we need to have a way of saying, I'm certain that I've had an impact on that that's good for this person. And so looking at, which part of my testing actually measures change with the nervous system over a period of time.
Because I love that idea. And you reminded me that when you taught me before of just define lead and lag indicators again.
Okay, sorry. Well. Yeah, it was probably
because they're pivotal to helping people on that visit to visit basis to answer that question of, hey doc, it's sore.
Yeah. So a lead indicator is really like a measurement that you can do visit by visit that says, yeah, this person is responding to my care. I know that I'm done for today. So I know that I need to do something for today. I know that I'm done for today. That's a lead indicator. It's something you can do that measures that their immediate state beforehand and then their acute response. And by acute, I mean shortened time frame, not related to acute symptoms. So you come in, I see you. All right, Angus, let's have a look and see how you're going. Whatever test tells me how you're going for the day.
Yes.
Let's do my thing and let's see that we accomplished a goal with what told me you were going. That's a lead indicator. A lag indicator is based on your initial assessment. It said to me that you had this period of this level of subluxation that had probably been there for a super long time. Let's remeasure. I'm expecting to see some changes in those things after 12 weeks. So if I give an example of what I would look in my practice, I would expect there to be change in your posture maybe over a period of time. I would certainly, if we look at the insight into nervous system function, I really like balance testing as a way of measuring, are you getting better afferent and therefore efferent input output to your nervous system, because your spine is doing better. And so balance testing would be two examples of lag indicators. You could also use other things as lag indicators, but they're things that it requires the body to adapt to over a period of time that reflect that bigger picture adaptation of their body to your care.
Yep. So for our listeners, if you're thinking the lead indicators that I used to use in practice, leg length was a big one. I practiced pretty much Thompson, so that was a big one that I would use. I would use some others that are perhaps a little bit more subtle, like breath as well, watching in terms of how that might be flowing through as well. Local tissue, in terms of, I found that there was very often and most often an immediate change in local tissues in the area that I adjusted as well. And then also kind of local static as well as active range of motion as well. So they were the things that I would check in amongst those kind of things. The lag indicators that I would look at, we used the subluxation station, we used posture, and then we would periodically re-x-ray. And then along that too, to be honest, one of the lag indicators often were the symptomatic presentation that the person came in with, you know, whatever that would be as well. And
so it's useful, I think, to clarify. So the paradigm that I practice with, we do measure what people's symptomatic response is. It's just got to be in a way that aligns with your philosophy and paradigm. So and aligns over a time frame that is reasonable. You know, it's not reasonable to have somebody expect their oswestry to change after one visit. It's just not the way that most issues change.
So, you know, our listeners, you have a bunch of different suggestions, and again, lots of these are very well supported by the science in terms of what should happen. You know, I as I talked about something, I understand that breath, for instance, would not be something that I'd want to stand up and justify somebody's care based on, but it's one of those things that I will look towards there too. I'd feel much more confident, you know, talking about range of motion, for instance, as an indicator as well there too. So
and I think it's useful to have a blend of those things. So we don't want this to be, to me, there's a balance of, you want to have the testing, you want testing that's useful. And the reality is that science lags behind practice. So it's okay to use things that don't have randomized controlled trials yet to support their use. It's also important to not be delusional and say, look, I can use just, you know, I can intuit it from the universe that this person needs an adjustment there. I sort of think it's helpful to have something that has been tested, like elements of palpation that you can have a degree of reliability, elements of range of motion, for instance, that have support in the literature. Those type of things, you want to make sure that you've got the check and balance of that, so that then as somebody, if say for instance, if somebody's your observation of their breath had improved, but their range of motion and a whole bunch of other indicators hadn't, you've got to sort of have the self-awareness to go, oh, maybe I just want to see that their breath's changed, and I need to pay. Might need a different protocol of care.
Yeah, love it. So
one last piece, if I can.
Yes, please.
I'll just loop back. So I sort of pieced all these pieces of the puzzle together. So we've got certainty in our philosophy. Then we've clarified and become certain in our paradigm by defining what the model of subluxation is, what the clinical rules are around who we will take care of, who we won't, how we take care of people, what is our job, what isn't our job. Then we've applied procedures that are congruent with that. And I've been through the clinical procedures part of it, the testing you're doing, the adjusting you're doing, how that interacts with that, and the timeframes over which we're expecting to see those tests change. We've thought that through around, is this reasonable and in what scenarios? And how would I sort of apply those tests to sort of get a sense of severity and chronicity? How bad is this, or how impacted is their system by their subluxations, their joint dysfunction, and how long has it been like that? So how much cumulative change do we have in surrounding soft tissues? And then the final piece of the puzzle is the communication piece. Like, how would I simply explain this to people in a way that made sense to them? Now, when I take people through a certainty workshop, there's not we're not going through everything you could do to define that, but we're getting at least the core piece of how we'd explain that core part of our paradigm and how our procedures plugged into that. And then, there's a lot of complexity to communication, as you'd appreciate, given how many times we've discussed it. But that's the basic structure: philosophy, paradigm, procedures, clinical, and communication.
What are the missing pieces that most people have in the communication that's costing them certainty?
I think for a lot of them, they've done things in a real kind of patchwork way, where they've said, I went to a seminar and this guy explained a subluxation as a loss of light, but then I haven't defined what my paradigm is. And if my paradigm has nothing to do with light, then this communication doesn't really align with anything. And so I have a thing that sounded really sexy when the person at the seminar said it, but I haven't defined it. Or they haven't sort of clarified the paradigm enough to explain phases of care in a way that is that they feel certain in, because they haven't plugged in what's the relevance of soft tissue healing timeframes for this person. Like, yes, there's a template around how we'd expect that, but is it the same for a 6-year-old as it is for a 60-year-old? Well, I would argue not. And then there's a lot of gradation in between.
Yeah. For me, it comes back to right where I started with, is I was trying to find certainty through communication, through clear methods of asking questions, of all that kind of stuff but there was no foundations that it was built upon. And so therefore there was an incongruency there, which was always going to lead to breakdown. It's fantastic. I feel like, that quote of the unexamined life isn't worth living. I feel like to some extent, the unexamined practice is going to be very difficult. It's going to be, a practice for me anyway, was difficult. We are working in a paradigm that goes against what the world says. For a lot of it, we have to think really clearly about these things if we're wanting to change thought processes and lead people through there as well. And it does take a great deal of introspection for us as chiropractors, but also to really examine what are we doing, how are we going about it there too. And sadly, at this stage, this process really should be taught to us at school in terms of critical thinking. And we should but we're not at this stage as well. So the course that you are in the final stages of putting together is going to be a really neat kind of delivery mechanism of that too, where it's not just, hey, go and buy it and do your own kind of thing there as well. Where are you up to with your current thoughts about how that's going to look to help chiropractors?
It's going to be a 4-week program. So the certainty program, taught a version of this over a number of years.
Yes.
And it's got that core flow of it as the original one did. But I did the Seth Godin marketing workshop a couple of years ago, and he has a fantastic way of, to me, getting the advantages of both in-person workshops and online workshops, and sort of getting, in some ways, the best of both worlds. So the advantage of in-person is that you kind of get that ability to get some feedback, and you're applying ideas to your style of practice and getting some feedback around your thinking on it, both from the presenter and from other participants. So there's that, we can't see our own blind spots. So there's a real advantage of that in-person immersive experience. The challenge with an in-person experience is you're limited. I'm in Melbourne, and people anywhere else either have to come to Melbourne to do it, or they can't do that. But also there's the downside of being the in-person model is it's by nature tends to be in one afternoon. And so you don't really get time to kind of think things through and go, all right, here's my first response to it. Actually, now that I've got somebody's given me some feedback to that, I can update that. And whereas the advantage of the online programs that we've done, like you say, is that, you can just buy it and you can consume it whenever you like, and you've got it there forever. So the idea with this program is it's 4 weeks. Beginning of week 1, there will be some lessons for you to do, some resources to support that, and then kind of an activity for you to do to apply these ideas in your practice, your model. None of this is me trying to dictate what your model should be. And then there's an opportunity for you to get some feedback on that from me and from other participants, so that you kind of get that benefit of a whole lot of people's thinking, and you get to get your blind spots seen, which sounds like it could be a bit intimidating, but it's a really friendly sort of process. It's just one of those things of, have you considered this? How about thinking about this? We resolve that conundrum this way, so that you get maximum value out of it. And so that each week you'll have that lesson, response, some feedback so you can refine it. And then a new lesson or series of lessons will be week 2, week 3, week 4. And you don't have to have week 1 lesson done and dusted. You can refine that as you go. And it's an organic process that allows you to kind of spend 4 weeks, essentially, like you say, the unexamined life. This is the examined practice, the examined career, the examined chiropractic perspective, but done over enough time that you can enjoy the process. There's not that time urgency to it, and you get that benefit of both sides of it.
To me, it's like you've got an online training from the pleasure of your own home, but with coaching, support, community, implementation, and the ability to refine, which is great. Buddy, where do people find out about it?
InsideOutPractices.com. And if you go to the online workshops, it's the very top one in the list there, Certainty 2.0.
Beautiful, dude. Well, all our listeners out there, if you're thinking about it, stop, just do it. Martin's stuff is really great. So, I can't overstate it enough. There are so many people across the world that overpromise and underdeliver. Martin, by his very nature, does the opposite as well. So he won't say stuff, so I will. It's great. Do it. So as well. Buddy, thanks again for a fascinating, riveting, wonderful conversation as well. And can't wait to continue to talk more.
Thanks, mate. I really appreciate it. Always love talking to you and love the opportunity to share with your audience. Thanks, mate.
Love it. Talk soon. See you, man.
Speak soon. Bye.
If you've enjoyed listening to this podcast, you have to come and check out my Community Influencer Program. It's my monthly coaching program where we take all this material and I'll work with you to help you apply it, implement it, and systemize it. The Community Influencer Group Coaching Program is designed to help you increase your practice income, impact, and enjoyment. Join me over at anguspyke.com/join. That's anguspyke.com/join. I'd love to see you there.